welcome. And thank you for attending the fourth webinar in the WHO Global Quality Round series. And this is the third one that's co-hosted with the International Society for Quality in Healthcare. So today we'll be on the topic of infection prevention and control and the water, sanitation and hygiene services, WASH for short, which are critically important for safe and reliable health services. So how can we maximise our resources, our individual and our team efforts to decrease surgical site infections, for example? Well, what has been shown to work? We have some very good speakers here today to share their experiences and are very grateful for their time. So please do use the questions and answers box. So there's a little Q&A box down the bottom of your screen. If any questions come into your mind during the presentations, and we'll get to them at the end. So some of our presentations will be pre-recorded and some will be live. So we'll start off with just a welcome from the ISQua CEO, Dr. Carsten Engel, and he's going to introduce today's webinar. So thank you all for coming.
Thank you, Katrina. Good morning, good afternoon, good evening, everyone. I wish to extend a warm welcome to all of you that have joined today's webinar in the WHO Global Quality Round series, offered in collaboration with the International Society for Quality in Healthcare, ISQua. In the previous two webinars, we had 94 countries represented in total, and it's great again to see so many countries coming to the webinar today. We can learn so much from sharing from each other and from the experts that are going to talk to us today. We will explore one important aspect of quality improvement, as Katrina outlined to you, hospital-associated, healthcare-associated infections, which are one of the most frequent types of adverse events seen in health services delivery, and thus an important cause of poor quality care. And to overcome this, we need to implement good infection prevention and control measures and practices, but WASH, water, sanitation, and hygiene services are equally important. So I look forward to hearing what the WHO, the researchers, and the partners who have implemented improvements in practice are going to share with us today. Over to you again, Katrina. You are on mute, Katrina.
Thank you, Carsten. Good thing I'm going to edit this afterwards. So before handing to our dear speakers today to explore the interconnectedness of IPC and WASH within communities and healthcare facilities, I'd like to take a few seconds to remind ourselves of the opportunity offered by these WHO Global Quality Rounds, co-hosted with ISQua. The quality rounds provide a virtual forum to highlight the critical role that quality of care plays in strengthening health systems and improving health outcomes. Today, colleagues from across the world are coming together to share learning through their experiences, challenges and successes. So these are really important addition to your continuous development and learning. So now I'm going to play a presentation from Mrs. Julie Storr. So she's a consultant with the WHO on IPC and WASH services, the foundations of quality care, inspiration and ambition from actions.
Thank you for the warm welcome. My name's Julie Storr, and in today's framing session, if it's okay with all of you, I intend in varying degrees to focus on each of the 5 areas listed on the screen as they relate to stopping infection and achieving quality care. I'm sure we'd all agree that the quality of health services is critical to achieving universal health coverage, and the data on this is vast, it's profound, and it's devastating. And it highlights how poor quality care does impact on people's health and on their lives as well. And it drives us on. The data drives actions at each level of the health system. And this quality planning guide, one of the things I like about it, published in 2020 by World Health Organization, is that it actually starts by asking, what do we really mean when we talk about quality health services? And I think that's important for today's webinar. So this planning guide talks about safe care that avoids harm to those who receive and provide care as an element of quality. And support for health workers is listed as one of the 5 guiding principles for system-wide efforts to improve quality. And it acknowledges that health workers often work in conditions that are difficult, that are under-resourced, and that hinder excellence, again, relevant to what we will be talking about today. We're going to probe some of those systemic conditions that affect the quality of our health services. And we're going to use a very specific example of one particular cadre of the health workforce, those who keep our health facilities, our hospitals, clean and safe, and to examine the reality of quality on the ground, so to speak, and how health workers can be supported to keep both themselves and people safe and thereby contribute to quality improvement. But I want to start with some important news concerning global mandates and norms and standards that impact and are relevant to a clean, safe environment in healthcare. And some of you will be aware of this, but even in May of this year, 1 month ago from today, the global strategy on infection prevention and control of the World Health Organization was agreed by all WHO member states. And this is important news for all of us in this field of quality. Just 2 weeks later, WHO and UNICEF issued their latest progress report on the status of water, sanitation, hygiene, WASH services in healthcare. And these two are interconnected, and they have inspired in part the angle I will take for the remainder of this session. So zooming on that IPC strategy, infection prevention and control, the strategy talks about access to healthcare as a fundamental human right. And it explicitly includes clean and safe care as a bedrock of high quality care. And it states that no one receiving or providing healthcare should be exposed to the risk of being harmed by preventable infections. Now, in some countries, your experience will be that it may be mandatory for health facilities to establish and implement IPC programs and practices and ensure basic WASH services. It may be the case in your reality, in many it is not. And as with the planning guide, the strategy states and emphasizes that all workers should have the right to safe, healthy working environments. And it outlines 5 reasons to invest in IPC. And I want to focus on the first of those in that visual here. I don't think it's any accident that the first of those is concerned with ensuring the quality of care and patient and health worker safety as a raison d'etre to invest in infection prevention and control. And over the next 7 years, up to 2031, in fact, the WHO, and I will be part of this work, will be developing an action plan and a monitoring framework for the implementation of this global strategy. And I want to briefly touch on WHO's IPC norms and standards, the guidelines, the evidence-based guidelines for infection prevention and control. Now, 2 of the 8 what are stated core components of an IPC program relate to this topic of clean, safe environments and those who contribute to that. And it's that purple section of the visual on the screen, that enabling environment that enables the delivery of safe care and safe practices. And this includes staffing levels, but it also includes the built environment, materials and equipment. And WASH, that's where WASH comes into play here as well as a pivotal element contributing to safe quality care and IPC. And it's quite simple. The very sort of essential level is this is about keeping health facilities clean. And to do so, you need access to water, to toilets, to the means to clean one's hands. We need adequate ventilation. We need effective waste management. We need access to personal protective equipment. So again, even going into more granular detail, we're talking about things like access to mops and buckets and disinfectants. And some of those are explicitly stated in WHO's implementation resources around how to make the guidelines come to life in the real world. And it's perhaps what we could quality. It's certainly different to some of the innovations and interventions that hit the headlines in healthcare conversations, but these fundamentals have an impact and they affect the spread of infection, they affect the spread of antimicrobial resistance, and therefore they affect outcomes. And we shouldn't overlook this in our quest to improve quality. So to the recent WASH Global Progress Report that really makes interesting reading. It does focus on the data, but it focuses on so much more. It's very solution focused as well. And so it's on two fronts. Yes, it looks at the data and the scale of the challenges, as you can see on the screen. Some of this data remains shocking in terms of access to water, to toilets, to hand hygiene at points of care. But in addition to the data availability, the report does outline a way forward, and it includes many case studies and it includes many voices of individual health workers across nations and how they have improved WASH and IPC and even environmental cleaning in the face of some of these challenges. But I did want to specifically stop for a second because this is relevant now to the rest of today's learning webinar. So as you can see here, there are two data points that are presented in the report, 2019 and 2021. And we've got great data from hundreds of thousands of health facilities on access to water, on toilets, on waste. But you will see here that there is no data in either of those data points on environmental cleaning. And this is searching all potential sources of data in the countries and facilities included. So keep that in mind. Why is this so? Should we be concerned? And what does it tell us? And I'll be coming back onto that in a moment. Now I want to go even further into some granularity and to just share some resources that were issued by the World Health Organization this year, a few months ago. And these are resources that aim to support those who train, those who clean, the cleaning staff in hospitals to a level of competence so that they can be supported in the work that they do. And these resources explicitly describe cleaners as a valuable component of the health workforce. And Professor Graham and her colleagues and Georgia have done some of the foundational and inspirational work upon which this WHO package has drawn and been based and extracted its structure and much of its content from. So the purpose of the package is to improve the competence of those who clean. It uses a practical approach targeted at adult learners. And it is the first WHO training resource for this group of staff that outlines the how and therefore does contribute to infection prevention and control. And I'll give you a very brief flavor of what is in that package. It starts by describing how to prepare, deliver and sustain the training. So the first part of the pack is a standalone and it essentially just outlines the how you go about it. The modules and resources in the orange part of the screen essentially contains everything you might need to actually run a training session. It's rich with visuals, with photographs, with cartoons of step-by-step procedures, lesson plans, evaluation forms, baseline assessments. It's big, it's multi-page, but it's essentially just a compendium of all of the different things you will need to deliver a training session. And again, going granular, how to clean a squat toilet, how to damp mop. There are scores of these visual illustrations that are based on the work that Wendy and her colleagues did. So now for my part of today's webinar, I just want to pose a number of what we might call trigger questions that could be picked up later in the discussion. And they're very much based on a review paper that I did a couple of years ago with some colleagues. And yeah, a series of questions around data, norms and standards, advocacy, funding and research. So first of all, we know from this year's WASH report that the data on environmental cleaning, there are huge data gaps. So how can we somehow convince those with the power and the decision-making capability to address these data gaps? How can we stimulate potentially different programs to come together to help us address these data gaps? Is that important? What are your thoughts from your particular experiences? In terms of norms and standards, they exist. We have guidelines, we have different tools and resources, and they continue to expand. But how can we ensure implementation, better implementation, awareness where it's needed? And again, is there some place for cross-discipline, cross-program collaboration in this area? And are there other questions that we should be addressing in terms of the norms and standards? In terms of advocacy, how might we maximize the impact of all of these resolutions and calls to actions and campaigns that exist across the world, across nations, to really try and support this agenda of keeping hospitals clean and safe? And is it beyond the realms of possibility to, again, bring different entities together to really do something in this area? In terms of funding, how can we, again, convince decision makers to invest more and more in keeping hospitals and those who provide those services competent and clean and safe? And again, would greater collaboration across different programs, across different organizations be of relevance in this regard? And then in terms of research, finally, there's a lot of research that's gone on in this area, and there is a whole new research agenda potentially that could contribute more to this field, and that's specifically what Georgia will be talking about in a moment. And just really finally, very quickly, I want to mention the quality toolkit that WHO issued, and I believe many of you will be fully aware of this. So before I hand back to the chair, this toolkit exists. It's an online, digital, searchable resource where you can access all WHO tools and resources relevant to the area of quality, and that includes tools and resources on IPC, on WASH, and on environmental cleaning. And if you haven't experimented with the toolkit, I would really welcome you to do so and to provide feedback on your experience. And on that note, I will thank you for your time. Look forward to participating in the discussion, and I will hand back to the chair. Thank you.
Thank you very, very much, Julie. And you might have noticed that Julie's video was covering some of the QR codes there. So we have them here for you if you want to get them. Okay, so next we will be hearing from Professor Wendy Graham and Assistant Professor Georgia Gunn, who are both at the London School of Hygiene and Tropical Medicine.
Thank you very much for that introduction, and good morning, good afternoon. It's great to be joining, and thank you for the invitation to be part of this grand round. This is going to be a double act. My name is Wendy Graham, and I'm joined by my colleague from the London School of Hygiene, Dr. Georgia Gong. Now, as you might imagine, from an institution called the London School of Hygiene and Tropical Medicine, we're going to do a double act about the role of hygiene and the importance of hygiene. You might imagine that from coming from this institution. But we're going to particularly look and zoom in on the issue of hygiene, environmental cleaning, environmental hygiene in relation to maternity wards. This has been an area of work that we focused on for the last 10 years, and Julie has already given a very kind introduction to mention some of our journey. And we're going to recount that journey a little bit more in a double act. Now, the sad reality of maternal and newborn health is rather captured by this very graphic image, a sign taken from a hospital outside, a sign taken from a hospital in West Africa, when the reality of the high levels of maternal and pediatric or newborn mortality in the hospital means that the co-location, as it were, of the mortuary and the maternity ward makes a lot of logical sense. But it also speaks to the fact that we still have a lot of preventable mortality happening in institutions. Some are because of complications that develop naturally or women present with these complications, but some of it is iatrogenic. And it speaks to this issue of first do no harm. One particular area of harm relates to healthcare associated infections. And as Jules has already mentioned, this is a very particular area. And in my presentation, and partly with Georgia as well, we'd like to talk about two particular parts. Firstly, about the special case of maternity wards and how they need special precautions when it comes to IPC and has a special place in quality improvement. And secondly, we're going to talk about the journey that we've been on, which has ended up focusing on environmental hygiene and cleaners, and that's how we'll complete our presentation. So the context of hygiene in maternity wards. Well, some of you might imagine, how long have we known it to be an important subject? And in fact, we've known about the subject, the importance of hygiene, in particular hand hygiene, the environment as well, for a very long while. Going back to the very famous Semmelweis, who's sort of the main person associated with looking at hygiene at birth, who introduced an intervention around chlorine hand wash and produced this dramatic decline in mortality. But actually, the person who really made the link between poor hygiene, poor environmental standards, was somebody in Scotland who in 1795, can you imagine, all those centuries ago, pointed out the importance of quality at the time of quality of care, the importance of hygiene at the time of birth. And it takes a long while. And even though those discoveries were made, we still find that in the turn of the 20th century, this is the Glasgow Royal Maternity Hospital, a lovely historical picture, when at this time, mortality was 4 times higher in the facility than at home. And that was predominantly because of the problem of infection and not following good infection practice. Once practices were improved from the sort of 1930s onwards, and with the introduction of antibiotics, there was a dramatic decline in maternal mortality. Sadly, that decline, we're still the sorts of levels of mortality we saw at this time in Scotland, about the 1900s, is still the level that we're seeing in many low and middle income countries today. Infection plays a large part in explaining that burden. One of the things that's happened in the recent past is there's been a rapid institutionalization of deliveries. So in the efforts to try and bring down maternal mortality, many countries have emphasized the importance of women delivering in institutions. And a lot of us would agree that that makes a lot of sense. However, it only makes sense if the quality of that care is good enough to prevent harm and to deal with complications when they arise. And this diagram just shows you for a whole load of low and middle income countries how the trajectory of the percentage of deliveries happening in institutions has increased. Some have been quite static, for example, in Cameroon, but other countries have seen a dramatic improvement. And that should really be leading to a reduction in mortality. But it does make this assumption that there will be good quality care. Unfortunately, when you start to look at the quality of care, and in particular the aspect of WASH and IPC, you start to see some staggering findings. These are data, they're actually rather old now. One of the pieces of work we're hoping to do in the near future is to update this issue about to what extent is the maternity ward particularly disadvantaged. And this shows you in Tanzania that for both hospitals, health centres and dispensaries, the extent to which they were what we call WASH safe is much lower in the labour ward, both for the hospital, health centre and dispensary. In other words, all areas, whatever the level of facility where women are delivering, they are typically delivering in very, very poor conditions. And I think that issue of needing to, I think we jumped a bit here. The reason why this problem continues is partly related to intrinsic issues of risk at the time of delivery. So we know that childbirth, any of you who have worked in maternity or in obstetrics will know the nature of childbirth means that there are wounds, whether it's the umbilicus or whether it's a cesarean section, that it can be a lengthy process in which complications can happen. So there are some intrinsic issues around childbirth that make it more risky when it comes to infection. But we also have what I call the perfect storm, which is a set of 6 elements, which at the moment are now making this a really urgent priority. We're seeing transitions in the type of women coming that are having pregnancies now with existing morbidities, which mean they're more prone to interventions, this massive uptake of care, in which case we're seeing a lot of overcrowding, this ongoing issue of poor water and sanitation, poor IPC practices in the maternity ward, weak information systems, so even when a woman goes home, she may develop an infection, but nobody back in the facility realizes that's what's happened. And of course, on top of all of this, the 6th element of the perfect storm is emerging antibiotic resistance. And if we don't have our antibiotics protected for these infections, we are going to be in a really deep problem. It doesn't take much to realize that quality of care is key. IPC is nested within quality of care, and there have been many frameworks developed to look at quality of care in and around maternity. And it talks typically about this issue of the provision of care as well as the experience of care. So it's both not just what is provided to women, but what women's experiences are as well. So what has been happening is some attention to quality by the M&N community, but typically the area of environmental hygiene has been neglected. And this example, visually very offensive. This is an example of a delivery table in the 21st century. We don't need to do any microbiology. We don't need to do anything in terms of asking health workers or women what they think of this delivery table. It's clearly unacceptable. It's clearly unsafe. And it's this issue of looking at this, how this could be changed. Now, many of these interventions are relatively low cost in the scheme of things that started our work. And so about 10 years ago, we developed a small NGO called the Soapbox Collaborative. Some of you might have heard of it. It was designed for obsolescence. It ran for just 7 years with a particular goal of putting poor hygiene in maternity wards on the map and being in much bigger attention. The research arm of Soapbox was run out of the London School of Hygiene, and although Soapbox itself has achieved what it set out to do, we are carrying on research, and Georgia will talk about some of that research a bit later. We started off by doing needs assessments, the visual. Never forget the power of the visual evidence. We carried out assessments with partners in country. We have permission to use these images, showing you issues of the poor state of infrastructure that Jules has highlighted to, showing you issues of floor patients, showing you the risk of cross-contamination when newborns are all placed together in the same bassinet. So our needs assessment work showed there was a really significant problem. And we started to do some work in and around this. We started off thinking, how could we empower women who are going into these facilities to be safer in what the care they were receiving? And we did some first work was done around birth kits. Women held birth kits so they could take into a facility so they could have a clean surface to lie upon. There would be a clean cord clamp, those sorts of women empowered issues. We then started to look at hand hygiene as well, because the environment, clearly hands play a very important part in the transmission of infection. And I'll just pass to Georgia to say a few words about our hand hygiene work.
Hello, everybody. Hope you can hear me well. So yeah, one of the first projects that we worked on was really trying to improve hand hygiene compliance in the context of Tanzania, and specifically Zanzibar. We worked across the 10 highest volume delivery hospitals, and it was a really interesting experience because in the context of the maternity ward, specifically the labor ward, you're often dealing with body fluids, and usually hand hygiene around body fluids is something that it's particularly important because you have a very key point of entry for germs. So when you're dealing with blood, urine, feces, and lots of potential for cross-contamination. So we focused a lot on hand hygiene before aseptic procedures, such as catching the baby, such as performing invasive procedures like using forceps or IV lines. And something that emerged was that the one thing that is often not discussed is not just the low compliance of hand hygiene overall compared to the guidelines, but also the issue of timing. Often birth attendants know that they have to wash hands or rub hands with alcohol gel, but often then they recontaminate those hands by touching surfaces they're not supposed to touch just before the aseptic procedure. And I just want to show you some of these results. Essentially, in only like 10% of hand hygiene opportunities we observed, out of about 800, across the 10 facilities, people were following the full set of guidelines. So they rubbed or washed hands, avoided recontamination, added gloves, and avoiding recontamination again. And we really found out how much contamination of gloves or hands was contributing to poor compliance to the WHO guidelines to hand hygiene. And this is why we kind of targeted our behavior change techniques for an implementation project onto not just increasing compliance of hand hygiene, so getting birth attendants to actually reach the gel or go to the sink and wash their hands, but also to understand this concept of recontamination of hands on surfaces. And we focused a lot on the environment. This is like a typical labor ward, high volume labor ward. And as you can see, it's really badly structured. Lots of cluttering, and the equipment is really poorly lined up for an efficient workflow where you have stochastic number of births coming into your facility. Sometimes you have to deal with multiple women. Sometimes there is nothing for hours, and sometimes you have to act quickly, and you have to, because every birth is very different from each other. And so as you can see here, you have the sink with the soap and the water on the left-hand side, sterile equipment over the table, the gel on a little trolley. There was no dry material available, and the gloves were actually often placed in the personal bag of the birth attendants. So the type of workflow you can work with in this environment is very poor. You have to perform hand hygiene before aseptic procedures hundreds of times a day. So we really focused on how we can facilitate behavior change among birth attendants by facilitating a better workflow and a better environment, and ultimately avoiding recontamination.
So this simple diagram sort of shows you this interplay of factors between the surfaces, the hands, mothers and babies, and instruments. And it's this issue of the surfaces. And as Georgia has just explained, hands are only as good as your ability to stop recontamination. So surfaces start to be very, very important. And this took us down this road of looking at environmental cleaning, which, as the quote at the bottom says, it's multifaceted. And it involves not only disinfection, cleaning and disinfection, but it also has these key elements of opportunity around training, leadership support, etc. So the journey that we took is an interesting one with a lot of visual evidence. We started off working in particular in India and Bangladesh, in particular when we were observing the crowding on these wards after delivery. We were looking at the sort of surfaces that women were using, that they were lying on. And what we ended up deciding to do was some basic microbiology. So we use these things, these dip slides, which is a relatively simple technology that can be pressed against a surface and gives you some indication of aerobic colony counts as a marker of burden or contamination. What we did is, out of that, and this bed here, the head of the bed is on the right-hand side, and these little purple grapes are actually Staph aureus, and it showed you that we found Staph aureus at the head of the bed around where the hands are, but also the feet. That made us start to wonder about why the contamination in the bottom of the bed, and we started therefore looking at things like mops. And my daughters refer to me as Professor Mop to Bucket these days, but mops turn out to be really important agents of change, but also potential risk of contamination. Mops, there's a science of mops, the way that we clean, the way that we prepare our mops is important. What we found was the mops often were spreading infection. And when we looked into that, we then started to ask to what extent the cleaners were trained, did they have an understanding of basic transmission of infections? And this started this 10 years, as it were, and almost now, of looking at the experience of cleaners, their knowledge gaps, what sort of response they have from their fellow workers. And as Jules has mentioned, typically a very neglected cadre that is not regarded as part of the healthcare workforce. One of the big gaps that we found, as well as knowledge, and that partly relates to issues of training. We were finding in very countries in which we worked, there was very little training, and at that time there was no package. And from that we developed this thing called Teach Clean, which had initially 7 modules. We then introduced ones which were about training and supervision and more generally quality improvement. Basically in October 2018, it was launched with these 7 modules, and it was rapidly picked up and rolled out in lots of different places. We've carried on continuing to learn and do evaluations about this, and Georgia's going to speak to one that is just coming to the end, the most robust evaluation that we've carried out so far. But the important thing was the issue about trying to embed this, see this not just as a project area, but also to recognize that it has to be embedded in broader quality improvement. So out of this, as Jules has already hinted at, there was then an opportunity for WHO to take our base package and to develop it into the WHO's own package. So this was released in 2018. On our journey, we've learned a lot about the sorts of barriers that cleaners face. They may understand what needs to be done, but they don't have the equipment or the supplies. They don't have the empowerment or self-efficacy. They're often neglected. So we've discovered lots of those opportunities to improve that sense of both responsibility, but wish to do good work. And I won't dwell on this one because these are what, for us, anybody who's in research, one of the greatest things to happen to you is when a product that you've developed gets taken up and used as a global public resource. So the fact that this is now Teach Clean is led and become the basis for a WHO package is really an incredible experience for us, and we're very pleased that WHO decided to take this on board. I'm going to turn to Georgia, who will talk about the most robust of our evaluations, which is one that is just coming to an end in Cambodia called Clean Frontline.
Thank you, Wendy. Let me just change the slide set briefly. I hope you can see it clearly. Yeah.
Looks good.
Fantastic. Thank you so much. So I'm briefly going to talk about Clean Frontline, and I'm going to share all these links right after the presentation. So this is a big endeavor between the National Institute of Public Health, WaterAid, the London School of Hygiene and Tropical Medicine, and the Ministry of Health of Cambodia. And this was a great experience because it was the first time, even though we've done several pilots in the Gambia, in Tanzania, it's the first time where we had the chance to really implement Teach Clean and actually partly the draft WHO package for over 10 months. And actually look at more aspects of quality improvement within that. So it wasn't just the training, there was also an element of supervision that was really important. Really briefly, the process kind of follows the WHO manual. We sort of always recommend starting with a needs assessment and contextualizing, adapting the training and supervision manual to the local context, which was run by the National Institute of Public Health and the District Health Services. And then for this project, the contextualization also included the design and creation of digital tools and materials run by WaterAid. Finally, we had a product that could be released for training. So the training of trainers meant that there were 52 champions selected from the 13 facilities that participated. And in turn, these champions went into their facilities and they organized training at the facility level, where they were responsible for training the people responsible for cleaning duties in those facilities. So we're talking about 13 hospitals across 4 provinces. So a huge endeavor also logistically. And on top of the training, though, we were really keen on trying to also experiment with some quality improvement and thinking about sustainability, we made sure that there was field monitoring. So from the district health services team, what we call master trainers, to the champions, but also make sure that the champions at the facility level had tools to supervise the cleaners in situ. And along the implementation, which was a huge exercise, we ran a process evaluation, which was run by an independent consultant. We also did a survey of beliefs and norms and so on. But we also tried to make this a really thorough evaluation, which was testing by using microbiology as a primary outcome. I'm not going to talk about this today, but hopefully we can release the data, which are quite exciting, by the end of the year. So yeah, I hope you'll see the results in a publication later on. So the first thing I want to highlight in relation to quality improvement is really the need for adaptation. And I think I really want to highlight some of the things that the Cambodia team did. This is the fantastic district health services team who worked over weekends and evenings to try and make sure that the contextualization happened before the training was released. And some of the aspects that had to be contextualized were actually the use of what equipment. So equipment that could be purchased locally, that was sustainable, that was part of the hospital budget, but also the digitalization of certain material. Actually, this picture of the blood spillage kit comes from one of the videos on how to clean a blood spillage that they produced, because they thought it would be good to leave some materials with people and the cleaners on their phones, on their tablets, so they can re-watch some of the training aspects. Another key aspect was also aligning the training and the standards with the available national guidelines for IPC. So this was a key thing that the DHS team, the District Health Services team, did. And finally, understanding what the local capacity could actually cater for. So we had a huge issue of very poor staffing. Number of cleaners per wards of interest, which we actually focused on the maternity wards, pediatrics and general medicine, was incredibly low. So we had to make sure whatever proposal was there during the training and supervision were realistic, given the number of staffing. So just briefly, again, linking it to quality improvement, it was incredibly important to pick methods that would be used at the hospital level. So for champions that were trained to then train, but also specially supervise cleaners, because obviously we all know that one-off training doesn't create change. So one of the things that is advocated for by the WHO resource is the observation checklist. So this is, for example, an observation checklist to monitor how cleaning ought to be done of a delivery bed. Another method that we use, which is quite cheap and very visually powerful, is what we call fluorescent gel, which is essentially a fluorescent gel that you apply to a surface. And then you can go and check a few hours later or after expected cleaning to see if it has been removed. And it's easily removed using a wet wipe. And so this is something that the champions could use to monitor if cleaners have performed the cleaning. Finally, and probably most importantly, was this idea of making sure that supervision included realistic cleaning schedule, which was actually the hardest thing to do because of poor staffing. And what we advocated for is to make sure the cleaning schedules had specific item. So how often you should clean a delivery bed, or how many times you should clean the disposal bin, and make sure that the frequency is stated, but at the same time that it's realistic given the resources that you have. Ideally, we would clean a patient area on a daily basis, but if you're completely understaffed, what is the best next thing that you can do, essentially? So really key is also the fact that the DHS, so these masters trainers, were providing continuous support to the champions. And how did they do that? Over the course of 10 months, they provided 2 in situ supervision sessions that actually included the context. So because they were actually going to the facility, they could actually see what are the challenges the champions were facing. And they continued communication through Telegram and through phone communication. And these are ways in which probably can be brought further by the local Ministry of Health, because they were sensitive to how the DHS actually already works in terms of QI. So in terms of integrating environmental cleaning in the Cambodia wider health system, you know, I think the really key thing in this project was that the master trainers were part of the district health service. That's the main thing, I would say. Some things that are planned are for the expansion of the subnational IPC training program with the environmental cleaning material that we produced over the Clean Frontline project, and specifically module 4, 5, and 7 of the original Teach Clean package can contribute to the development of standards, operating procedure, and specifically in relation to the accreditation system, which we think would really integrate the environmental cleaning standards into the health system. So hopefully these things will happen. They will just not be plans, but we're really excited to share these experiences with you. So passing on to Wendy for the concluding comments.
So in terms of what we've tried to cover here, firstly, the issue of maternity wards, it is special. Of course, I mean, as a professor of obstetric epidemiology, I'm bound to say this, but actually I hope you're convinced that there are specific areas of infection risk related to childbirth that do need special precautions and special attention. This is now urgent. There is growing problem around what we call the perfect storm, a set of factors that are making this problem much, much more significant and increasingly so. And at the moment, environmental hygiene, as Jules shows, it's not being monitored well. One of the things that we want to shine a light on is to what extent maternity wards continue to be disadvantaged in the area of environmental cleaning. Around Teach Clean, it's almost obvious to say that training alone is never sufficient, but we were really surprised by the extent to which the training uptake, the change in knowledge, that was often very good. The issue with the enabling environment was weak. So issues about practicing the good things that the cleaners were taught was often the weakest link. There does need to be ownership. I fear that environmental cleaning falls between several different potential silos within health facilities and also within health systems. It needs to have a proper grounding and be owned, whether it's through WASH or whether it's more broadly called quality of care. I don't know, but it does need to have ownership. And the issue about the agents of change, cleaners, we are very struck wherever we've worked about how they take pride in what they're doing, how they're often severely underpaid and severely overloaded, but they do need to be regarded as part of the healthcare workforce. And I guarantee from now on, every time you see somebody cleaning, you'll notice them. I'll pass to Georgia, who's going to talk about the research agenda.
Yeah, so the last thing we were asked sort of to comment on actually is how we think that the research agenda on environmental cleaning is going to move forward. So, and in the last year, we've tried to compile quite a lot of evidence to understand what are the cleaning interventions in low resource settings. And as you can see, there is a lot of systematic reviews available on cleaning interventions, which have been published relatively recently. However, none of them cover low resource settings. None of them included papers on low resource settings. So, of course, as researcher, we decided that there were too many gaps. There are too few rigorous studies. The reporting quality is very poor. As I said, very few studies from minimal resource settings. There are no standards outcome on the definition of cleanliness and often lack of contextual description. So it's really hard to know, is this facility actually well equipped or not? And we've actually conducted alongside our own systematic review that was really trying to get at the few papers who exist on low resource settings. And even those ones, unfortunately, are very poor quality, very small scale. So what we thought is that we should gather experts around the table to understand, okay, we do know that we need more primary research because the ones available out there is not good enough. So what are the research priorities moving forward? And we were really lucky to be funded by UK PHRC. And this is just an example of how we work together as a stakeholder team, as much as cleaners team do. We were trying to aspire to do the same, to be really collaborative across people from different agencies, from different parts of the world to understand what the research priorities are. This is a great picture from one of my colleagues, and this is a hospital where actually cleaners, together with doctors and nurses, operate cleaner once a month all together, which I think it's a really nice example of working together. And so we run together this the clean workshop again, that it was kind of pulling together a series of experts to try and prioritize on the research needs. And what we focused on is implementation research. So research needed to enhance implementation of best practices around surface and non-critical equipment, and specifically focused on resource-limited settings. And of course, it's a collaboration among different agencies. And essentially, what we came up with is that we wanted to call on funders to invest, policymakers to enable and support, and advocates to promote and fill in these gaps. And what are these gaps? We recently published what is called the Clean Briefing paper that you can see available online. And it's a brief document that highlights 12 priority research questions. And here is the link, and I'll post it on the chat in a minute. And just to give you a bit of a flavor, there are different categories of question. One is around standards. One of the questions was, what are the human resource requirements to achieve microbiological cleanliness in different types of healthcare? Because we still don't know, how many, for example, beds per cleaner shall we aim for? In terms of system, we know that the cleaners cadre is particularly neglected, coming often from poor socioeconomic background. There is a gender lens. So what are the health system level factors that can support professionalization of cleaning staff? With regards to behavior change, we were really focused on sustainability. So one of the research questions we picked was, what are cost-effective strategies to sustain cleaning behavior in terms of both cleaning frequency and quality? And also we had a category about innovation research questions. For example, is the use of detergents alone non-inferior, I would say sufficient, compared to use of detergent plus disinfectants in reducing the bioburden of low-touch surfaces? I think another thing that the Clean Briefing does is to try and highlight some of the considerations that implementation researchers and funders should think about when they think about environmental cleaning implementation. And we have several issues like accountability. Environmental cleaning shouldn't be just a cleaner's responsibility. It should go across the whole healthcare system and across all the healthcare level. Another one was the status of cleaning staff. As I said, often coming from poor backgrounds, low literacy population, and neglected cadre, as we call it in one of our publications, an invisible cadre often. So that needs to be taken into account when you're doing both implementation and implementation research around environmental cleaning. And there is a series of other sort of consideration we highlight in the Clean Briefing that I would welcome you to read. So I just want to thank you so much for listening. And these are all the signatory of the Clean Briefing. So we're really proud that so many people kind of subscribe to this research agenda, and we're hoping we can convince funders to sort of and advocates to promote this research agenda. Thanks so much, everybody.
Wow, thank you very, very much, Georgia and Wendy. A picture can speak 1,000 words, I think. So yeah, thank you for sharing this incredibly important work. And I think you've stimulated some important questions. We'll probably all look at our environments differently now, and the teams cleaning in the hospitals and clinics, we'll see them now in a new light. Well, I will certainly. So thank you very much indeed. So I'm going to start sharing my screen again now. We have one more presentation. Okay, I hope you can see that. So our next presentation is from Dr. Lewis Akko-Egbe. We've seen some powerful research into IPC now, and the work being done by Teach Clean and the Soapbox Collaborative to improve and educate. So this next piece from Lewis will explore how compassionate leadership is what Lewis calls the cream on the cake for IPC. And he's going to share lessons that he's learned from a subnational level in the health system in Cameroon.
Good morning, good afternoon, good evening. I'm Lewis Akko-Egbe, a medical doctor by training. So I will be speaking from a very practical point of view on how compassionate leadership can actually influence IPC and WASH practices in primary healthcare facilities. The case here is Cameroon, in Central Africa. So we'll be using this as our outline for the presentation. I'll first of all just paint a little picture of Cameroon, the context from which these case examples have been chosen. It's a country in Central Africa, about 22 million inhabitants, which has 10 regions with 360 health districts. Cameroon is a breadbasket that's called the breadbasket of Central Africa. As you see, there is around the Horn of Africa, but it has also a lot of health issues ranging from high maternal mortality rates, high under 5 mortality rates, to low patient personnel density, but also the allocation, what is spent on health from the GDP is also low, but a lot of that is spent at the central administrative levels. So you see just 10% goes to actually the operations at the district and health facility levels. But this picture is gradually changing with the implementation of performance-based financing. We also have Cameroon a very high out-of-pocket expenditure. So this is the district where I served in Cameroon. You see that the district, just to provide how the district supports the health system, is actually linking the National Ministry of Health to the health facilities on the subnational level, the population, the health facilities. And the health system of Cameroon is still very hierarchical, but as a manager, you'd want it to be more result-based and more flexibility to be able to take actions that would change the way services are provided. So also in Cameroon, since 2016, there has been this socio-political crisis that has actually caused a lot, affected lives, but also health facilities have been closed, some burned down. So the picture I'll be presenting are some of the benefits and the gains that we had prior to the crisis. So it might not be the same picture as this crisis has caused a lot of damages. So we all know quality of care is the backbone of universal health coverage. And IPC is very central to the provision of quality of care because you need that germs are prevented, microbes prevented or limited the spreading. And so we've been focusing a lot on the technical aspect of IPC, but more and more now we coming to terms with the behavior of people, the social aspect of IPC, how it affects the results that we get. So most of these lessons have been learned from COVID, and we saw how human behavior actually compromise the effects of infection prevention and control, some of the strategies that we put in place. So leadership is very key in influencing the 5 building blocks and IPC also. So this is, you see here, the interplay between quality and IPC. What are the relationships? So you see that IPC is very central in the provision of quality of health services. But we have also, in addition to the implementation of IPC strategies, we have the policy environment in the form of national quality policy and strategy, also IPC guidelines, and also patient safety guidelines. So all of this has to do with the cultural change, and that has to come from by learning quality, but also learning the interventions and the practices and principles of IPC. And then we see also how very central compassion is to the provision of quality of care, which has been universally accepted that it has to be effective, safe, and person-centered. A lot of literature has been generated on the importance of compassion, which you cannot overemphasize, both to the patient, to the care providers, and to the health system as a whole. So this is the center of my presentation on how compassionate leadership actually affects or influences infection prevention and control. So the 2 case examples, one is at the facility level, and so this was a subnational level, a sub-divisional hospital in the rural part of Cameroon, where we realized that we're observing a high rate of post-operative infections. And we came to the realization that IPC is not designated for just cleaners and IPC focal persons. It was everybody's business. And so we needed to build a compassionate workforce, an environment where everybody felt that their contribution was appreciated. So the goal was to reduce surgical site infection, but also to set and maintain a clean and hygienic environment that would attract patients to our hospital. So we did kind of a DEX review to understand the scale of the problem, that's the surgical site infections, from the funds that were generated in the hospital, and with the collaboration of the hospital management team, we hired some cleaners. But very importantly, we reinforced cleaning as a role for all the health professionals, nurses, midwives, labs, technicians. And we instituted a monthly cleanup campaign, which was supported a lot by the community. We had community stakeholders like the motorbike riders who were bringing patients to a hospital. They participated in this. And we demonstrated leadership here by also participating in this cleaning. You know, the doctors, myself as the director at the time, would come out and clean, and it motivated the personnel, also motivated the community dwellers to see that cleaning was a priority for the hospital. That notwithstanding, we developed IPC job aids, we did orientation for the staff, we installed water points, hand washing points at various strategic areas in the hospital, and we adapted and implemented the WHO surgical checklist. Also, mandatorily, all cases of SSIs were reviewed and action taken to solve the problems that were identified. So we had these results, which were very remarkable at the time. SSI rates reduced, there was increased adherence to checklists, improved compliance to the IPC protocols. All SSI cases were reviewed and recommendations acted upon. And then we experienced dramatically an increase in service utilization. Our OPD and hospitalization units were flooded with patients. And this was really the dividend from the work that we did. At the district level, this was a district in another region in the Bangam Health District, which I was opportune to serve as the district medical officer, but also accumulated as the director of the district hospital. So these are some of the roles that the district team carried out: facility visits, supervision, engagement with community stakeholders to understand the health problems of the community. And just to point out that it was a very difficult district. And so to get results, we needed to do things differently. Some of the indicators at the district level is timeliness and accuracy in reporting. And so we were really lagging in this, and we had to do things differently. So what did we do as a district and as a manager? I realized that there was a need to organize services rooted in compassion that supported the facilities, but also the personnel. And so we set up a social platform at the district health service that included the personnel from the hospital, from the health centers. And through this, we had these monthly meetings. We conducted staff visits during bereavements, but also anniversaries of staffs. And we supported them in also following up their documents at the national level, because it was a headache working in such an environment with difficult road networks to actually follow up your papers at the ministry. And also we organized routine outreach to these health centers, because some of the health centers were barely abandoned. Patients were not going there. So, but when they hear that a doctor is coming to consult, it boosted their influx. In some of them, which were comprehensive, we actually did surgeries, and it was really appreciated by the community and the OICs, the officers in charge. So this is just to paint a picture, summarize what we did. The district and the hospital has all of these inputs from the national level, but what from the lessons we learned in the hospital and the district, we kind of cascaded this IPC kits in the form of guidelines, supplies to the health centers. Also, data management, we did reviews, we conducted supportive supervision, and we supported them in maintaining their registers. But at the bottom, surrounding all of this and underlining this was the compassion, the environment that we built, that was actually, stimulated all the personnel to work and to own the services that they provided. And there was this cross-learning also between health centers when the opportunity set. So at the end of the day, we had a district that was, the indicators improved, the reporting improved, also services that were provided at the health facilities became more safe, effective, and people-centered. So this was one of the results we recorded. There was improvement of some of the services, like you see, maternal mortality, incidence of nosocomial infections dropped drastically. Timely submission of our reports, and there was improvement in the trust and collaboration among personnel, both at the district health service and at the health facility level. Personnel were more willing to go an extra mile, to take initiative and take action at the health facilities with minimal support from the district or from the Ministry of National Ministry, the Central Ministry of Health. Of course, there were challenges, both internally and externally. You see the limited knowledge on IPC principles and practices. So we had these orientations to correct this. Inadequate staffing. We also corrected this by locally recruiting some personnel, especially the auxiliary ones like the cleaners, to support the workforce. There was also resistance to cultural change, but in an environment that is compassionate, this became very easy to roll out. Staff turnover was also an issue. Externally, like I mentioned earlier, the armed conflict and also the COVID pandemic, they caused a lot of disruption to the services that we had set up. So what lessons have we learned? Or what lessons did we learn? That community involvement is crucial in the success of every health intervention. You saw the involvement of the communities and how it supported the functioning of the health facility and the improvement of IPC indicators. It is also difficult to be compassionate when you are not shown compassion. So most of these health workers who, when I took over, were blamed for negligence, were blamed for abandoning their post, became more present at their post, became more welcoming to the population because of the environment we created. Compassion is the core of quality health services. We cannot overemphasize. Like I usually say, it's like the cream to the cake. And we also have learned that political will and compassionate leadership is important to change and to reinforce culture, like what we saw in the IPC practices. IPC is not a function reserved for cleaners or for IPC focal persons. So it needs the whole team to take IPC WASH as a role that is mandatory for all to carry out to ensure the safety of patients. So we have some references, and I want to thank you very much for your listening attention, and to say that let's all take on the role of infection prevention and control and look at IPC beyond just a technical component in our work, but look at its social ramifications and the social dimension of IPC and how it would impact the care that we provide to patients. So thank you very much.
And so that concludes our presentations for today. But I'm going to hand over now to ISQua, who's going to reflect on what we've learned today and summarize some of the great presentations and the key lessons from today's webinar. Thanks, ISQua.
Thank you so much, Catriona. And if I could just invite all of the speakers, if they're online, to just put on your video so we can see you as well. Some really fantastic presentations. And I think in those presentations, you've kind of answered some of each other's questions, I think, or the questions that I had in my head and the questions that we've seen appear in the chat. So I'm not going to do you justice. I'm just going to just highlight some key takeaways and insights that actually struck me as I was listening to each of your presentations. And so, Julie, I mean, you started off with the global picture, and you know, what do we mean when we talk about IPC and the interconnections with quality. I think you highlighted the opportunity of the global strategy for infection prevention and control, and all of the work that's being done on, you know, getting these big political commitments to working in this area, and really charging WHO as the secretariat with driving an agenda that brings the key stakeholders and partners together. And you know, you really reminded us that the goal is around stopping infection and achieving quality of care, and then you sort of went into speaking more about what that meant and looked like. You also sort of touched on the importance of normative standards and data, the need for advocacy and funding and research, and then the other presentations kind of took up those particular areas. Wendy, I mean, I think when you said this is the perfect storm, when you look at the needs of maternal health and childbirth, and I think as a mother and as a parent and as a nurse, for me, I think childbirth is special in many different ways. We heard about your 10 years, over a decade of work in this area, and some of the approaches that you took, and the need for really understanding what you were trying to do in the first place, and the importance of doing your research and carrying out a needs assessment and seeing what is it that we're dealing with, what's happening, and what data do we need. You also spoke about the power of visual evidence, and I think that was really powerful, that, you know, you can talk and talk and talk, but when you see a picture, and Catriona mentioned this, it really drives the message home without having to say anything, and the use of visual evidence as being a powerful driver. You also spoke about, you know, the need to the various ways in which you experimented, tried different things, got feedback, and then developed some really powerful and transformative approaches. We heard from Georgia about some of those, the projects in Cambodia, the work in Cambodia. You said that actually this work is not a project, it's a way of doing business, and that it's everybody's responsibility. And I think for me, what struck me was the importance of the linkages between process and outcomes. And I think for many of us who work in healthcare, when we've been trained in a kind of log frame approach where you have inputs and outputs, process tends to get lost, and it's only in the realm of QI that process becomes more prominent again. And so I think there's a real challenge in changing the narrative around the linkages between processes and outcomes. And I think you've demonstrated the impact of that when you do bring the two together. And this is also important in making visible the invisible, because when you were talking about, you know, the intersection between germs and people and surfaces and how there's visible parts and there's invisible parts, and so you've got to bring together feedback mechanisms that enable you to understand data in a different way, and then use that data to be able to then take action. And then we have Louis' presentation that really was an exemplar of great practice in terms of how do you do it, and what do you need to think about. And I think what struck me, multiple things struck me also in his presentation, but I think the one thing that he wouldn't say is actually his role in driving transformation and change. And I think that's an area that I think we need to explore, because it takes people to be able to lead change, and that leadership is actually navigating what Louis talked about, the culture, the bureaucracy, the hierarchy, the mindsets, the different technical areas, and actually looking at who are the key champions and who is it that needs to be valued in terms of addressing infection prevention and control at the most local level. And I think also how the statement that you can't provide compassion if you yourself are not given compassion. And I think that's something that I keep coming across over and over again, particularly in healthcare, is a lack of compassion for the health workforce and what they need to be able to do what they came into the professions to do, and creating those environments where people can collaborate and partner and support each other. And how leadership actually is important for modeling that change. So those are just a few highlights. I didn't cover everything, but there's some of the things that struck me. And I'm just going to go open up the questions now. We do have some questions on chat. If you want to ask your questions in person, I will also keep a lookout for anyone that has their hands up. But I think we'll just look at the questions in the chat, and there is this question on from Kusnadi from Indonesia, who says that environmental cleaning needs stronger ownership. Would you tell us how to build it? And we've touched upon some of those points, but is there anything else that we need to be thinking about in terms of getting stronger ownership across the key stakeholders that need to address it? And maybe I can turn to Wendy and Georgia first for that, and then to Julie.
I think there's no magic wand, and I think it does vary. But I think, Assia, as you mentioned, it's really important to have agents of change, and they may exist at different levels. We've been very fortunate with our partners to work with individuals who are passionate, compassionate and passionate about this area. And we shouldn't underestimate that. Unfortunately, you can't randomize, or you cannot bottle these individuals that have this passion, but you really do need someone who's going to champion this. And sometimes it comes from unusual places. I mean, we've certainly seen in some situations it can be the domestic superintendent of a large hospital. They're not a healthcare professional per se. They're actually someone who's a professional in their own area of housekeeping and domestic work. But we need to invest in those individuals. I would say, that's what I'd say. I think that to start off pushing and nudging forward, you need to find these champions, and you need to get behind them and support them so that they can do what they're good at, which is convincing and taking everybody else with them.
And just to add to Wendy, though, one thing that we kind of lived through the experience in Tanzania and Cambodia in particular is that in spite of very motivated individuals, often there are still really real contextual barriers that they cannot overcome by themselves. So, like lack of staffing, if you don't have a sufficient number of cleaners, you cannot perform cleaning on a daily basis in an effective way. If you don't have a budget line, and if you don't have enough resources. So I think we have to be really real about what amazing positive deviants can actually achieve in an environment with really poor resources. So I think we cannot forget also the other part.
Thank you. Julie.
Not too much to add, Assia, but just to build on what Wendy and Georgia have said, I think it has to be multimodal. I think, the whole culture of an institution or a facility is critical in terms of how people are supported, but you do need all of those, the system change and everything else around it. And just looking at the participants, there are many of those leaders and inspirers and influencers on the call today. So I would just really encourage people, if you're not part of the Global Learning Laboratory, to join, because that's where you can actually share with other colleagues some insights and ideas that build on everything we've heard today from our colleagues, Wendy, Georgia and Louis. So I really put a rallying call out. That Global Learning Laboratory is only as good as the people in it, and it's been revamped. Give it a try, have an experiment and join the conversation, and so that we can really truly share and learn from each other, because that often is how things change. Thank you.
Thank you, Julie. Yeah. And it's unfortunately Louis wasn't able to be with us today, and so I think getting in touch with him and actually grilling him and asking him how he solved problems, I think is going to be really, really important, because as you say, there are contextual factors. Yes, Wendy, go ahead.
And I think the thing also is to congratulate him. I mean, I think sometimes we forget how, how tough it is and what people have been through. And to get the recognition from this community is really, really powerful. For somebody like that, who was obviously working in very difficult circumstances, I think praise is part of the solution, to be honest. It's along with compassion, but being very upfront about those people who have been agents of change and have achieved a lot.
Yeah, thank you. Absolutely right. Let me turn to the people, the participants. Now, I don't see any hands. Is there anyone that would like to ask a question? Yes. Kedar Sauleshwarkar. Apologies for how I pronounced your names. Go ahead, please.
Thank you very much. Although I joined a little late, I missed an earlier part, but it was wonderful to listen to all the experts. What I wanted to know is, sometimes we are faced with gram-negative sepsis outbreak in our NICUs. And as you know, newborns are very vulnerable to infection and their complications and mortality morbidity is quite high. So in order to curtail the outbreak of gram-negative sepsis in infection, what are the approaches that can be taken? So can you please throw some light on this?
Okay, so I couldn't hear you quite well. So your question is some of the approaches that would be helpful in addressing what types of infections?
Gram-negative infections in neonatal intensive care unit.
Right, that's a highly specific question, and I'm not sure that we were able to do that. Wendy, yeah.
I'm just to be very practical about, I can send an article about that talks very practically about the gram-negative. We have some experience of some of the work in the Gambia, but if there's a way of sharing email, or we can put it through, I can share the paper.
Yeah, that would be great. So if there are any specific technical questions that people require help with, then we can collate all of those, and please do join the Global Learning Laboratory, because that's where there is a repository of resources, and you can continue to engage with a wide variety of experts on that platform. Are there any other questions?
There is also in the chat, Asia, what some of our colleagues, Sonali, who's responded to that specific question as well. So I think there's a bit of crowdsourcing going on here as well.
Right. I think that's one of the beauties of having expertise spread across many countries. So it's great. I'm just seeing if there are any more questions in the chat. Okay, so again, I think there are some questions around advocacy and support promoting change, and there's a question from Angeline Chiocha, who says, how do we convince authorities to involve IPC experts in designing the hospitals? So, Julie, do you want to offer some thoughts on that?
Hi, Angeline, great to hear from you. So again, I think, I could share in the chat lots of different resources that WHO have developed around how to implement IPC, and it's back to that issue that we keep discussing. It's multifaceted, and it does depend on the leadership, the people, but also the structures and the context. And design, getting that right is a challenge in every country of the world, getting that input right at the very outset, but it is about building a strong IPC program, a strong team with credibility, with influence. And so, yes, I can share some of those implementation resources, but again, I'm sure there's some really rich contributions from around this virtual table who can give you some very practical insights as well. And whether Wendy and Georgia have anything to add, I would welcome their inputs here as well. But yeah, it's a great question, and it is a big challenge, but there are ways that this can be addressed by building that strong IPC team as part of quality and safety and AMR. And that issue of integration is coming across loud and clear, and that's something we are really majoring on in the next phase of work, because IPC cannot exist in an echo chamber. It has to be seen as part of the overall quality agenda.
Yeah, thanks, Julie. Georgia.
Yeah, I mean, I think it's an interesting angle design. I think it depends what we mean by design. If we mean like actual physical infrastructure and architectural design, or if we mean equipment and things that can be more movable within a ward as well. But taking that specific lens, I think there is a lot that we can learn from, for example, emergency medicine, when you're dealing with like really fluctuating workflows, for example, and workloads. So I think from the maternity, I got a lot of inspiration from emergency medicine, because they have to deal with unpredictable number of patients and they have to move fast. So it's how you facilitate health workers' behavior in the easiest way to have to do what they have to do hundreds of times a day, by making the environment as easy for them as possible. I know it sounds like a stupid example, but I don't have a square table in my house, because I would bump into it and get bruises all the time. I have a round table, and it sounds silly, but that's essentially what it is how to think about people in space. And there are some good organizations that have quite a lot of expertise in thinking about interior design for hospitals, and I think we can draw from that, and as well as emergency medicine, I would say. But it's very much like a department specific issue, because it depends what the type of procedures and type of patients are in each ward.
Yeah, thank you.
The only thing I'd add to that is this power of the visual. I mean, one of the things that's very striking is a picture speaks 1,000 words. I mean, you have to do these things respectfully. You have to think about the ethics, and you have to sort of think also, I mean, you shouldn't just loosely use images. But we've always used, and including participatory photography, when we gave cleaners cameras to take pictures of the scenario that we're dealing with, and that was incredibly powerful, what they were able to do with that participatory photography. But I would say, I think it's so crucial to, it sounds very obvious, but things like, we developed a toolkit called the walkthrough, and it took you on a journey through a facility, and you taking pictures at certain places. But there's nothing like, of course, visiting good examples and examples where the improvement is needed. But there's something about the physicality of seeing and being present as part of the design process is really, really key. And I think of all the statistics I've worked on over 35 years, I think one image can capture so much more than all of that data. It's not that you need one or the other, you need both, of course. You can't just deal with anecdote, but there is something about the physicality and the impact. And I think also one of the things that Georgia in particular and our team have looked at is this issue that some people get very fatigued with images that are not good. But if you get beyond that, you can learn huge things from an environment where clearly, as Georgia showed, walking from one place to another, you're very likely to put your hands down, your clean hands, and recontaminate. There are things about actually the sort of, as I said, the essence of being there and seeing. So we should never forget visual evidence, as ISQua was saying at the beginning.
Thank you, Wendy. Thank you. And we do have Louis, who've joined us. Louis, can you hear us? I did see his face pop up a few minutes ago. Maybe he's having. I think
his internet is quite weak where he is at the moment.
Okay. All right. So we are coming towards sort of the 4:30 mark, I think, when Julie, yes, go ahead.
Just quickly, just some hot intel. Apparently we've had an influx of new members of the GLL, the Global Learning Laboratory, even in the last few minutes, who are already sharing and discussing. So that's really good result, and I hope people feed back to us as well about the experience. Thanks, everyone.
Yeah. I mean, I can sense that there is a rich, deep sort of well of experience that people bring, and I think the Global Learning Laboratory is a good place to be able to share that. And this webinar is not to sort of provide be all and end all of expertise is actually to start and share inspirational stories and experiences, but also get people talking to each other and sharing across learning. So I think it's really important to continue the discussion and the conversation. There is one issue that I think that keeps coming back, and that was really all around integration and sustainability. Those are two huge challenges, and I think the clues to addressing it lies in many different places, and I think what would be great is if particularly those two issues can be really discussed in depth within the communities of practice. Because I think there's probably some really good gems in country level experiences as to sort of what has worked and what isn't working in terms of the continuous commitment that's required to drive this agenda and actually get multiple stakeholders to have a shared ownership for IPC. So I know that it's we're two minutes over. Catriona, do we wrap up now? And
yeah, I think that's a great way to move on, is if people do want to keep talking and discussing and supporting each other, to move over to the GLL website there where people can chat. And yeah, I think that we'll have to wrap up now. Yeah. But I want to say massive thanks to everybody who contributed to this brilliant webinar. And like any good webinar, it has some fantastic answers, research, examples to share, which has produced even more questions. So everybody, I think, has had their mind changed in some way today, which was excellent. And I want to say massive thanks, and also thanks to everybody who came to the webinar, and a really great fruitful discussion afterwards too. Good questions there too. And we've been asked numerous times if we will be sharing presentations and recordings, and yes, of course, tomorrow, once this has been recording has been edited a little bit, I'm going to send out a link to anyone who registered, and also in that email I will include some of the resources, or all of the resources that were mentioned today, with links to download, and also the GLL link to join as well. So without further ado, again, thank you, and we will be in touch next time. We will have another quality round webinar in the next few months, and we want to say hopefully you'll all be there again, and take care, have a good day, and see you then.
Thank you.